Good afternoon, everybody, and welcome to this European Society of Intensive Care Medicine webinar. We are today joined by two excellent expert speakers. We have Massimo Girardis from Italy and Charlotte Summers from the United Kingdom. And today we're going to be discussing what we can learn from COVID. Clearly, COVID has been a major challenge to intensive cares across the world over the last 2 years. And we've all had to learn extremely fast about a disease that we hadn't encountered previously. We've obviously learned huge numbers of lessons about COVID, but the question here that we want to ask is, can we translate that learning to other diseases that we see in the intensive care unit? Because as rates of COVID do start to come under control and vaccination gets started or continues, the case mix coming through our units is changing radically, and COVID is in most places no longer the dominant disease. Other diseases are available. So the aim of today is to discuss with these two excellent speakers about what we can learn from COVID. First of all, Massimo will be talking about the biology and what we can learn from that. And then we'll hand over to Charlotte, and she will talk about therapeutics and what we can learn from that. And I think the key questions will be, what can we translate to other diseases, and what can we not translate, or what should we not translate immediately, and where should we be careful? So without further ado, I will formally introduce Massimo Girardis. So Massimo is the chair of the SAS section within the Intensive Care European Society of Intensive Care Medicine. He is head of anesthesiology and intensive care at the department, the Anesthesia Intensive Care Department at Modena University, and Professor of Anesthesiology and Critical Care Medicine in the University of Modena, and also at Reggio Emilia. His clinical activity and research are mostly focused on intensive care medicine, with a particular focus on infection, sepsis, and oxygen transport. And he works from basic pathophysiology through to therapies. He's coordinated numerous research projects supported by national government funds and scientific societies. He is well published with over 200 index publications and serves as editor and reviewer for numerous high-profile scientific journals. He was previously the deputy chair of the SIS section, and as I say, has recently been elevated to the chair. So it's a great pleasure to welcome Massimo and to hand over to you.
Thanks a lot, Andy. Thanks for the presentation. Great opportunity to be here. It's very, very important to have just this afternoon together for discussing a lot of, I think, important points on COVID-19, of course, but particularly on the future that will be COVID-19 and sepsis together, or I hope without COVID-19, but maybe together. Just before to start, here you have my disclosure, not particular disclosure, specific disclosure for this presentation. And my agenda will be starting from the basic, this is pathobiology. I just want to make some comparison between the usual bacterial sepsis and the viral sepsis of COVID-19 and the differences between the two. And I move on the cytokine storm, very big issue, particularly for the management of this event, and I'm sure that Charlotte will spend a lot of time on the discussion on that. And in the third part, the last part of my presentation, I just want to show you some point on the immune dysfunction, probably late dysfunction in patient in the ICU with the sepsis and COVID-19. Before to start, I just want to say you that I try to prepare my presentation using a simplification of all the mechanisms involved in the pathobiology, in the cytokine storm and dysfunctional immune system. And of course, this puts some limits in my presentation. First of all, the high complexity is quite difficult to simplify, but I think more important, it's quite difficult to manage heterogeneity. And heterogeneity in COVID-19 depends on many factors, but mainly by the patient. Heterogeneity in bacterial sepsis is a completely different situation because heterogeneity depends on the bacterial and, of course, also on the site of infection. It's quite difficult I think, to summarize all the heterogeneity in a presentation or in daily life. I would just want to start with, just a reminder on definition of sepsis. We changed our approach to sepsis since, I think, 5-6 years, moving from systemic inflammatory response and then to dysregulation of the host response to infection. And this really, I think, is a change of approach, in not only in consideration, in publication, in research, but I think also in the clinical evaluation of our patient. In the right part of the slide, I put the mechanism leading to organ dysfunction and also to the control of sepsis. And I underline some point that I think that has been mentioned in the last year many times in the scientific literature as well as in the common newspaper, in the public newspaper, is endothelial cells, coagulation system, immune response, and so on. But I think that if we look to this picture on the right, we can understand that at the end of the story, viral sepsis as well as bacterial sepsis have this main mechanism, probably different, and I will stress the differences between the two pathologies, the normal sepsis and the COVID-19, but at the end, I think that coagulation system, endothelial involvement, and immune dysfunction is the key features in both bacterial sepsis and viral sepsis, specifically COVID-19. Before to discuss on the differences, I think it's important that after 2 years, we realized that probably the infection to SARS CoV-2 is not just a one-hit model, but is at least 2 or 3 hit model. Because we started the beginning of the story 2 years ago with just in mind the bacterial infection, a very strong hit with the cytokine storm, and then controlled by our immune system, by antibiotics and immune system. This is not true. For sure, in patients with COVID-19, in fact, we know now we have at least 4 phases of disease, starting from infection of the upper respiratory tract, pneumonia, lung dysfunction, then systemic loop and systemic inflammation and loop between the endothelium and the lung in a sort of persisting inflammation and, of course, then immune dysfunction. I think that one of the major differences that we observe in COVID-19 compared to sepsis is the involvement of the endothelium, and particularly in the hemostasis and the balance between hemorrhage and thrombosis. This depends on too many factors, the cytokine, the activation of complement. Probably hypoxemia played an important role in causing microthrombosis. The replication of the virus in the cell may have another important role in maintaining this kind of activation of the endothelium, and particularly the coagulation, prothrombotic coagulation. I think this is important because during sepsis, we have usually a prothrombotic phase followed by a hemorrhagic phase. The intravascular disseminated coagulation is rare in patients with COVID-19, whereas in patients with COVID-19, we usually have a prothrombotic phase, very persistent prothrombotic phase after days after the infections. And the other point I think important as difference between the two infection is this point. This is angiogenesis. At the end of 2020, this publication in New England stressed that is a histopathology study in 7 patients with COVID-19 and 7 with influenza, and they observe, of course, in the lung sort of inflammation, perivascular inflammation. It's important to know that in patients with COVID-19, the microthrombi it was 9 times compared to patients with influenza, and the same was compared to in the lung, and the same was for new vessel growth. It was around 3 times larger than patients with influenza. So the endothelium involvement, and specifically the coagulation and the new degeneration new vessel is completely different in COVID-19 than in other sepsis. Influenza, but quite the same for bacterial sepsis. I move now to Cytokine Storm. I will have a summary at the end of my presentation of the differences in pathobiology. But now I move to Cytokine Storm. I remember the first patient in my unit was February 2020, just 3 days after the first patient in Italy. And, you know, the data coming from China say that we have a very important difference between survivors and non-survivors in terms of pro-inflammation, and in very high inflammation of the patient, high C-reactive protein, high pro-inflammatory cytokines in the patient. At that time, the model was 1-if model. The cytokine storm was the reason for all the disease that we were seeing in our patient, interstitial pneumonia and thrombosis, and at that time, without prophylaxis, also some myocardial infarction. But after that, at the end, and the proposal, you have a Lancet published in March 2020 say, oh, pay attention, it's important in these patients, consider cytokine storm and use immune suppression, steroids, cytokine blocking agents, intravenous immunoglobulin. And I remember why, because we were involved in many trials during the first wave in Italy in 2020, and also many patients receive as compassionate use of steroids as well as tocilizumab. But after that, at the end of the year, putting together all the information coming from literature and comparison, the question is probably cytokine storm is not different from or compared to patients with bacterial sepsis. Maybe rather than patient with bacterial sepsis, in particular patient with usual sepsis and ARDS may have more cytokine production in the first phases of after infection, as well described by Peter Picker's group in this famous, I think now, paper in the upper part of my slide. It's quite the same in the bottom part. Another study showed that in patients with other pathology different from COVID-19, the pro-inflammatory cytokine as well as TNF-alpha are usually high at ICU admission than patient with COVID-19. And the question is why, when we try to use cytokine blocking agents in sepsis for decreasing the cytokine storm, we failed in the randomized control trial since at least 20 years, but they cannot. Now we know they have some beneficial effect in COVID-19. This is an open question. I think that with Charlotte we can discuss about that probably. An answer, in my view, could be the difference in time. Time, you know, is difficult to study. It's difficult to have. It's easier to make an observational study at the beginning of the story, at the ICU admission. It's more difficult to follow the patient during the ICU stay. But it is an elegant study published in Frontiers of Immunology last year. The authors showed that in comparison with the bacterial sepsis, the orange line, the patient with the COVID-19 during the ICU stay from day 1 to day 21, they observed an increase in cytokine compared to bacterial sepsis. Of course, as the other, at ICU admission, the level of interleukin-6 in the blood, interleukin-8, interleukin-1, and TNF is higher than in patients with bacterial sepsis than COVID-19, but after 1 or 2 weeks, we have a different trend of the cytokine, persisting of cytokine storm in patients with COVID-19 compared to patients with bacterial sepsis. An hypothesis, I think, real. Of course, the effect of antibiotics in comparison with the no effects of antiviral now is important in patients with COVID-19 patients with COVID-19. Last part of my presentation will be dedicated to immune dysfunction. Here you have an all-in-one picture of the trajectories of patients with the sepsis, bacterial sepsis, or the red line for hyperinflammation and early death or recovery or persistent hyperinflammation leading to the famous peaks, or on the other side, you have at the same time a sort of adaptive immune response leading to immune paralysis. And as we know now, the occurrence of opportunistic infection or other dysfunction of the immune system. Is it the same in COVID-19? First of all, I forgot, here you have the mechanism, well-described mechanism, all the immune response, innate, adaptive, cellular, cytokines, checkpoints, all are involved in dysfunction during or after bacterial sepsis. Monocyte deactivation, low expression HLA-IDR, downregulation receptor, apoptosis of lymphocyte, anti-inflammatory, hyperproduction of anti-inflammatory cytokines. So we have many factors, many mechanisms. What's about in COVID-19? Very early in our center, we understand, we got that probably COVID-19 is more than cytokine storm. We had a lot of patients with dysfunction in the immune cells. We got a lot of information from basic immunology during the first wave. And the mechanism during the immune mechanism leading to immune suppression are quite similar to that observed in patients with persistent bacterial sepsis. Changes in T lymphocyte activity, increase of Tregs, decreases in B efficiency in production of immunoglobulin. Quite the same picture, definitely the same picture in patients, but probably with a different occurrence in terms of time and entity intensity of dysfunction. Together with our friends of European Group of Immunology, we summarized this situation in this picture. After the early immune response to COVID-19, we observed we can divide the patient in two groups. One is with mild disease and the other with severe disease. And of course, the difference is the immune response and the appearance during the severe disease of immune paralysis and frequently secondary infections. So, what are the analogies and the differences between the two? In terms of pathobiology, I think that, as I said before, the analogy is the dysregulation of immune response, a very early endothelial involvement, both in bacterial sepsis and in viral sepsis, the probability to have multiple organ dysfunction for endothelial involvement, and the high heterogeneity, quite important. What the differences? In bacterial sepsis, in terms of pathobiology, probably frequently we could move from one single organ to multiple organ failure or shock. I think that the big difference between bacterial sepsis and COVID-19 sepsis is the coagulopathy and thrombosis and thromboembolism. Cytokine storm. Cytokine storm is an event both in bacterial sepsis and in COVID-19 in the early phase. In bacterial sepsis, commonly we have a more robust response at the beginning. In COVID-19, probably we have a more important role, could be a more important role of cytokine in the late phases during the course of the patient, maybe in the ICU, and that's, I think, quite important. Immune dysfunction, immune paralysis. The mechanisms involved are similar. The immune and clinical consequences are quite similar, particularly secondary infection. What are the differences? And I think that in bacterial sepsis, usually you could observe a progressive occurrence of immune paralysis, whereas in COVID-19 admitted to the ICU, usually we have a very important immune paralysis since the beginning, with a pronounced pattern of immune dysfunction. And I think this could be due to the difference in the control of infection. In fact, I think that viremia and viral replication play a role. This is my last slide. This is for me now a focus, waiting for a good antiviral drug, because there is a clear relationship between viremia and the severity of the patient. Now you have the graph on the left part of the slide. Patient in the ICU, the more severe patient usually have an important load of viremia in the blood, and there's a clear relationship between viremia and the pro-inflammatory and cytokine storm and immune paralysis. So I think that could be the reason why we observe difference in time between bacterial sepsis and COVID-19. Just an assist for Charlotte. I think that my presentation wanted to highlight the problem of where is our patient and where is going the patient in terms of immune response for using immunotherapies. And I think that it's important to know the viral load, to know what are the system in pro-inflammatory, immune paralysis, and the probability or the scenario with the secondary infection. My take on pictures, as usual, are 3 pictures. The first one, please start to think about immune response, not only to the severity of the pathologies as indicated now in the guidelines for using steroids or other. The high complexity and heterogeneity of the patient is a problem and will be a problem in sepsis as well as in COVID-19. And remember to measure something to consider differences between the patient. I invite again to discuss about that in the chat of the eLive TV of the European Society. And after this webinar, of course, I'm available for discussion by email. Thanks a lot.
Excellent. Thank you very much, Massimo, for that comprehensive overview in a very brief time of the immunological changes that we see in COVID and how they relate to patients with sepsis. As Massimo said, please do post questions in the eLive TV chat. And when we come to the discussion section at the end, we shall try to address the questions that come up. So moving on from what's going on in the patients to what we might do about it and how those findings from COVID may or may not be translatable to other diseases. It's my huge pleasure to welcome Professor Charlotte Summers, who's a colleague of mine from Cambridge. So Charlotte is Professor of Intensive Care Medicine at the University of Cambridge and also a practicing consultant in intensive care in Addenbrooke's Hospital in Cambridge. Charlotte undertook her undergraduate training in Southampton before moving to Cambridge to undertake a PhD looking at the role of inflammation and pulmonary transit of human neutrophils in the lung, whilst also completing her training in intensive care medicine. She was then appointed as a clinical lecturer in intensive care medicine before securing a Wellcome Trust Fellowship and Fulbright Fellowship, which allowed her to move to the University of California, San Francisco, before returning to Cambridge to take up an academic post. As I say, is now Professor of Intensive Care Medicine here, leading a wide range of projects, both focusing on fundamental host biology and also treatment, perhaps of relevance as chief investigator on the HEAL COVID study of post-ICU, post-hospital recovery in COVID patients. So I shall hand over to Charlotte and we shall hear what we can do about other diseases.
Thank you, Andy. I'm not sure whether you can hear me or not at this point. Yeah, you can, perfect. So I thought I would take a slightly different approach to Massimo and think about what are the higher level lessons that we could learn from the pandemic that might apply outside that with a slant looking at it from the point of view of therapeutics. And so the place and the first lesson that I thought I had drawn from the pandemic overall is that we are not very good at saying we don't know things. And this was highlighted really early on, I think, particularly in the American system, where the FDA gave emergency use authorization to several therapies without having clinical trial evidence to suggest that they actually had a benefit. The first one I thought might be worth highlighting was that in March, or early on, 2020, they authorised convalescent plasma as a potential therapy for COVID, having had no randomised controlled trials of this therapy in the setting of COVID at all. It had previously been used to some promising effect in other viral infections such as Ebola, but there was no data at all from COVID. And in fact, it was decided in the United States that it was too hard to do a clinical trial that was randomized in the setting of a pandemic. So they just used registry data, which they thought might have a benefit for the therapy, and licensed it on the basis of that. However, we found subsequently, when the recovery trial in the UK did do a randomized controlled trial of high titer convalescent plasma, that it was of course of no benefit. So recovery randomized 11,500 people, half of whom to standard care and half of whom to 2 units of high titer convalescent plasma, and found no impact on 28-day all-cause mortality. Similarly, at one point, hydroxychloroquine and chloroquine were given emergency use authorization in the United States, and there were many, many members of the public and clinicians who were advocating for this therapy. But to date, almost all of the data suggests that not only is there no benefit from hydroxychloroquine, but actually in some settings, using hydroxychloroquine is harmful. And this led to the FDA to revoke their emergency use authorization of chloroquine and hydroxychloroquine. So it shows that many of the things that people's gut instinct or initial assumptions were going to work and were what we needed to be giving to our patients actually weren't. But rather than saying, I don't know, let's find out, many areas of the world decided that they would just press on and give these therapies outside of a research setting. And I think that's probably the big lesson from the pandemic for all of us. Nothing else probably caused more controversy at the time than the role of steroids and whether we should or shouldn't give steroids to patients with ARDS. And just to give a little bit of background, early in 2020, the DEXA-ARDS study by Villar and colleagues came out in Lancet Respiratory Medicine, and it suggested that there was possibly a benefit for dexamethasone therapy in patients with ARDS. The hypothesis was that early adjunctive dexamethasone in people with moderate to severe ARDS might decrease mortality and mechanical ventilation. And that dexamethasone had never been used in the setting of ARDS in a randomized controlled trial, despite its potent anti-inflammatory actions, and that previous data about steroids in ARDS had been, I think, politely described as inconclusive. There were advocates on both sides of that debate. So what did they find? Well, the primary endpoint was ventilator-free days at 28 days after randomization. And they had some secondary endpoints of death from all cause 60 days after randomization. They enrolled 277 patients, so it really was a phase 2 study between March 2013 and December 2018. And the trial was stopped early for low recruitment because 277 patients over 5 years is not quite the recruitment rate most people would want to see in a clinical trial. But at this point, they've got 88% of their planned total recruitment. And as you can see, actually dexamethasone increased the number of ventilator-free days at 28 days. So 12.3 ventilator-free days with dexamethasone versus 7.5 in the control arm. It also improved survival at 60 days, their secondary endpoint. So there was early data suggesting that certainly in non-COVID types of lung inflammation and ARDS, it may well be that dexamethasone may be of benefit. However, when it comes to viral infections, there was lots and lots of controversy about whether there was any role whatsoever for corticosteroids. And just to highlight this, this is from February 2020 in the Lancet, that very clearly reviewed the literature and said that they felt the clinical evidence does not support corticosteroids for what we were then calling 2019 novel coronavirus-related lung injury. They very helpfully reviewed all of the data that was available from other coronavirus and other viral infections, and were concerned that the risk-benefit ratio was adverse. So in MERS, there was some data that suggested that actually corticosteroid therapy delayed clearance of viral RNA. From SARS-1, again, suggestions of low clearance or delayed clearance of the viral RNA from the blood. It was significant, but the effect size wasn't clear. There were also the complications that we've all seen with corticosteroids of psychosis and diabetes and avascular necrosis. Worryingly, from the influenza literature, there was also a suggestion from a meta-analysis of 6,500 people that there may be an increased risk of mortality in people given corticosteroids in the setting of influenza-related lung injury. And over many years, data had suggested that for respiratory syncytial virus, there was no benefit in children who had RSV if they were given corticosteroids. So this meant that when the recovery trial announced that they were going to do a randomized controlled trial of dexamethasone in hospitalized patients with suspected or confirmed SARS CoV-2 infection, it's fair to say they got a lot of correspondence suggesting that this might not be the best idea that anyone had had. And it was a very polarized debate. But they did what I think we should always do when we don't know, and that is to try and randomize and to learn rather than assume that we're right. So they randomized patients 2-to-1 to usual standard of care or standard of care plus 6 milligrams of dexamethasone once a day for 10 days or until discharge, with a primary outcome of 28-day all-cause mortality. And as we all know now, they found over time in their population where 89% of them had confirmed in a laboratory SARS-CoV infection, and 16% are receiving mechanical ventilation and 60% oxygen. We were giving a lot of other therapies that I'm not going to talk about today at this point in the pandemic, but we don't tend to use azithromycin anymore because the evidence for that being of benefit has faded. A few patients were getting still at this point hydroxychloroquine or other antiviral agents. So their primary outcome was, as I said, 28-day all-cause mortality. And actually, there was a reduced mortality in the people who had their 10 days of dexamethasone, which was very much not the result that had been predicted for this study. As you can see, the difference was for the overall trial was a reduction in mortality. The mortality was driven predominantly by people who were not on oxygen. So the benefit lay with people who were receiving invasive mechanical ventilation or people who were only having oxygen therapy. So these were pre-specified analyses that they did so that they could try and work out exactly who we should be giving these therapies to. And so the standard of care in the UK and in many places across the world rapidly became that hospitalized patients who required oxygen or mechanical ventilation should receive 10 days of 6 milligrams of dexamethasone. There was other work that was done across the world on various different other steroids, which was beautifully synthesized in a meta-analysis in JAMA by the REACT working group, who pulled data from 7 RCTs, and this is just of the critically ill patients from each of the studies. 678 of them received steroids and just over 1,000 usual care. Again, they used the 28-day all-cause mortality and looked at adverse events too. And across all of the studies, 28-day mortality was lower in patients who received corticosteroids. And it didn't really matter whether it was dexamethasone or hydroxychloroquine that you received, there was a benefit with all of the steroids, which slightly calls into question the conclusion of DEXA-ARDS was that the reason their study showed a benefit and other studies in ARDS hadn't was because they used dexamethasone, whereas the REACT meta-analysis concludes that it's a class effect rather than a dexamethasone specific respect. But I don't think we really know the answer to that yet. To take this work further, the 6 milligrams dose of dexamethasone was not an evidence-based dose. It was one that was picked because you have to pick something to put into your trial protocol, and it was thought to be probably a reasonable dose. So it was a pragmatic decision. Anders Perner and colleagues looked at higher dose and lower dose corticosteroids with dexamethasone in people receiving oxygen and randomized to 12 or 6 milligrams for 10 days. And their outcome that they used was the number of days you were alive without invasive mechanical ventilation, circulatory or renal replacement therapy support. And they found that actually there was no difference between 6 or 12 milligrams of steroids for your median days alive without support. So there was no statistically significant difference. But equally, there was possibly a trend towards a reduced 28-day mortality in those who received the high-dose steroids. But importantly, this was not at the cost of increased severe adverse reactions. So this left us in a situation where we know dexamethasone is good for corticosteroids, but we don't really know whether high dose or low dose is better. And in fact, we don't know what we mean by high dose or low dose, how high should we go, and for how long. So there's still quite a lot of open questions. One of them hopefully will be addressed by one of the newer arms of recovery, which is looking at high versus lower dose, currently in the UK, having done it in the international arm of recovery too, so that we can try and build on the steroid 2 work. But it's fair to say we still don't really know all of the questions, all of the answers to the questions around steroids in COVID, let alone in ARDS and other causes of lung injury, such as influenza, where we've previously suggested it might be causing harm, but actually there's no good randomized controlled trial evidence. I think the other lesson that I wanted to highlight very briefly in my part of the talk is that whilst we're very good at saying we're absolutely sure that we know the answer and not building on the evidence that's needed to provide those answers sometimes, we're also quite good at saying that an answer that we've generated in one setting clearly is relevant to another setting. And I think in the pandemic, there's no other better example of this than anticoagulation. Very early on in the pandemic, many critical care physicians were absolutely convinced that full therapeutic anticoagulation in patients in the intensive care was of significant benefit to them. I think if you'd asked a lot of people, they would have told you it was unethical to do a randomized controlled trial because they were so convinced of the benefit and didn't have equipoise. However, it didn't quite work out as we assumed. And I think it was even more surprising than perhaps we'd thought. Anticoagulation in REMAP-CAP in critically ill patients. So this was an open label adaptive randomized controlled trial for patients receiving organ support from high flow nasal oxygen, NIV, invasive mechanical ventilator, vasopressors or inotropes. They randomized 529 people to therapeutic anticoagulation and 545 to usual care thromboprophylaxis. Now, it's probably important to mention here that usual care was somewhat variable because some people felt they didn't have equipoise about giving what they'd given their standard pre-pandemic thromboprophylaxis. There's a little bit of variation in what that was, but there was reasonable separation in terms of the doses overall. The primary outcome that they used was an ordinal scale combining in-hospital mortality and the number of days you were free of cardiovascular and respiratory organ support to day 21. And much to everybody's surprise, therapeutic anticoagulation was not superior to usual care thromboprophylaxis. And even on top of that, 3% of patients receiving therapeutic anticoagulation had a major bleeding event. So no benefit at an increased risk of harm compared to if we did standard thromboprophylaxis. There's still some open questions in the critically ill patients about whether pre-pandemic standard prophylaxis versus what's sometimes called intermediate or augmented prophylaxis is appropriate. I have to say it wouldn't surprise me in the least if there's absolutely no benefit from anything above pre-COVID thromboprophylaxis. But we won't know until we do the trial, and that arm of REMAP-CAP is going on currently. I think the thing that surprised me most was that in non-critically ill patients, so the exact same protocol was done in patients who were hospitalised but not inside the intensive care unit. So they had thromboprophylaxis with the same outcome measure versus standard thromboprophylaxis. And therapeutic anticoagulation had a benefit in this setting. So if you're not as sick, therapeutic anticoagulation had a 99% probability that it was superior to standard thromboprophylaxis whatever you were using in the pandemic. And for most people, it was pre-pandemic thromboprophylaxis for their ward patients. Certainly in the UK, most wards were not giving augmented or double dose thromboprophylaxis. They were giving what they'd always given. And compared to that, therapeutic anticoagulation was a benefit, but for the intensive care patients, it was not. So not only are we not very good at saying we don't know, let's ask the question, we're also not very good at saying, I'm absolutely sure I know the answer to this. And it also will be the same for this group over here because I know what I'm talking about. Neither of those things turn out to be true. So what are my conclusions for this bit of the talk and the lessons that I'd like you to take away? Well, firstly, it's that medical professionals often think they know things they don't, that randomized controlled trials are in fact possible at scale in acute settings. And I think that's going to be an important thing for all bits of intensive care, but definitely for acute infections. And contrary to some parts of the world that said it was not possible, such as America, to do RCTs, we absolutely can. And lastly, answers from one setting do not always translate to another quite as we imagined. And with that, I'll finish, but show you how you can get hold of me if you have some more questions.
Wonderful. Thank you very much, Charlotte, for that overview of therapies in COVID and reminding us all how things have changed. And certainly the discussions around the advisability of the use of steroids in COVID-19 take me back to 2020 and some of those discussions and so forth. So as you say, it goes to show we often don't know what we don't know. And the way to find out is to do trials. So we're now going to move to a discussion section. So if people have questions to post, please do put them on the eLives TV chat. I believe there's also a Facebook forum where these things can be posted as well. I know, there you go, Facebook, very 2019. So if I can open the questions then, and I'll put this to Charlotte first. What antivirals do you think that we can use in COVID, and when would you use them?
It's a really complicated question and getting more complicated by the day. So there is some evidence, and it's fairly weak, I think, for intravenous remdesivir, and probably more effective in some groups than others. And then there's emerging data to support molnupiravir and Paxlovid, but I would caution about both of those because the trial data to support them having benefit was done in high-risk unvaccinated populations as yet, the RCT. So move out from molnupiravir and the Paxlovid equivalent, the name of which escapes me, were in people who were at high risk of hospitalization who were unvaccinated. We don't as yet know what the impact of those will be in highly vaccinated populations, of which large numbers of European populations are. There's an ongoing trial called Pandemic in the UK that's an antiviral platform trial that's randomized, I think, about 8,000 people now to molnupiravir. So people who are over 50 or under 50 with high risk conditions for hospitalization to see whether it does in fact keep people out of hospital. So more news to come. But I think for most people, early antiviral therapy is probably better than late antiviral therapy. The caveat to that would be people who are not immunocompetent. So there have been cases where there's been prolonged viral infection, and actually those may well contribute to the formation of variants. So there are some very immunosuppressed people for which there have been some fantastic publications from various different settings suggesting that actually the virus mutates in those people and can be a cause of new variants, which is something to keep an eye on, I think.
Excellent, thank you. And Massimo, can I turn to you and just put that question in a slightly different way? To what extent do you think the pathogen dynamics alter or affect the differences between bacterial and COVID sepsis? So obviously in bacterial sepsis, most of the patients who come to ICU have active ongoing bacterial replication at the time they present. And yet with COVID, although these patients often have high viral loads, they've often stopped shedding active virus relatively early on in their stay in ICU. So do you think that's important in how in both the pathophysiology and how we manage them?
Great, Andrew. I tried to answer you, but before I just want to have a question to Charlotte, but after my answer. So what about the monoclonal antibodies in patients with hospitalized patient? Okay. Anyway.
Okay.
I think that the crucial problem, as Charlotte mentioned before, is that we have two different high heterogeneity in immune response of the patient to viral infection, to COVID-19, and it's completely different to bacterial sepsis. In some way, when I have a patient now arriving in my ICU, fully vaccinated with a severe respiratory failure due to COVID-19 is quite similar to an hematological patient with bacterial sepsis. So, I mean, it's a patient where I can really have many weapons to use for managing his immune response or to managing infection. And you know, in patient with hematological disease and neutropenic patient, you can use many grams of antibiotics, but at the end, the bacteria will stay in your body. And the same in COVID-19 without any immune response in patient, in fragile patient or hematological or transplanting patient fully vaccinated. So I think that it's quite important to have this idea and important to measure the immune response of the patient in terms of specific antibodies against SARS-CoV is a part of the story, as you know. And the other is the possibility to understand where is the immune functioning of the patient. As an example, you know, the lymphocyte count as the neutrophil to lymphocyte ratio, or the HLA-IDR expression of the monocyte is a very good measure of the possibility of the patient to have a good response to infection, bacterial and viral infection. So it's complicated, but I think that we have to realize this point.
I guess just to loop back to the antiviral monoclonal antibodies, even that's become more complicated in recent weeks with the emergence of Omicron. So the recovery trial had shown that resembles, the neutralizing monoclonal dual antibodies combination, had improved outcomes in patients who were hospitalized, and that was prior to Omicron. Unfortunately, that monoclonal antibody does not look like it's particularly effective against Omicron, having been well effective against Delta. There are other monoclonal antibodies that look like they may in a laboratory be effective against Omicron. And so Sotrovimab is currently in recovery to have a look to see actually if that does do the same against Omicron as Ronapreve did against Delta. So again, we've gone from having something we knew improved mortality back kind of down the snakes and ladders a little bit to, with the emergence of variants, to not being as confident that neutralizing monoclonals against the virus are as good as we thought they were.
So there's been a very interesting chat comment from here. It says, excellent talk, which is always good. One of the things that we should have learned is that the problems where we don't know shouldn't necessarily be discussed in public, because that might cause confusion. And a second question has been raised about, and I slightly dread to raise this one, but about the use of ivermectin, which I suppose is another area where there is perhaps some discussion about the utility of that. So perhaps I could turn to Charlotte actually on that one just to start with. Should we wash our scientific dirty linen in public, and does that risk contaminating discussion, or should we be open and honest with people outside of our immediate scientific field?
So I think there are different points of view on this, and so I can only give you my personal one. I think that at times of pandemic, more so than any other time, communication of science and uncertainty and the process behind science and why we do it and how we do it to build trust with the communities of which we are part is really important. I don't view it as washing dirty linen in public. I view it as an ethical obligation on all scientists and medical practitioners to be honest about the things we don't know, to do our very best to answer the questions we don't know, and to share with the public the uncertainty. Because every time we don't and we hide things, or we say we're certain about things we are not, we damage trust. And actually, that's probably done more harm over the course of the pandemic about people's trust in science and healthcare and doctors than the times we've had proper conversations with the public. And often our research is funded by public money. So I would say that we have an obligation to share with them all aspects of our work, including why we're doing it and the uncertainties. Ivermectin, one very brief, very clear sentence from me on this. As far as I am concerned, there is no evidence to support the use of ivermectin in hospitalized patients with COVID-19.
Okay, Massimo, do you want to follow up on the ivermectin comment, or in fact on the one about the openness and open discussion about uncertainty?
About ivermectin, we have many patients coming from the community with ivermectin therapy. For sure, we have no data for that, but Italy is special. So I think many other countries, but Italy in particularly, a lot of physicians, general practitioners now are using different therapies in patients at home, and this is a risky situation. But the confusion is high and the communication was bad, particularly in my country for at least one year and a half. And my perspective, many things, but my perspective is that probably the scientific societies should have a different position in the discussion. I think that at least in my country, many single person discuss on the TV, on the newspaper, as well as on the Facebook about which is the right therapy and other, but not the societies, not the infectious disease society, not the anesthesia society. It's the same. I think Maurizio did a great job during that period, but probably for the public, the role of scientific society in governing the information was not so clear. And I hope in the future that the European society as well as the national society will have a more important role in communication, scientific communication to the public. This is my suggestion here in Italy, but maybe also in the rest of the world.
Healthcare is all about trust, and we have to actively build trust. And sometimes we're so busy in our labs or in our clinics or at our bedsides that we forget we're part of a wider context.
Yeah.
No, very, very wise words there. A lot of the conversation and a lot of the chat is coming in is still very specifically about COVID. So I'm going to carry on that theme. Massimo, there's a question here on which dose of dexamethasone do you think people should go for? And do you have an opinion on the role of what's described as steroid pulse therapy? I think that probably means high dose pulsed methylprednisolone in COVID. Do you use it? And if so, when?
Yeah. Interesting question. First of all, I just want to say that probably in the future we will have no more one approach to all the patients. An example: now we have data coming from phase 4 trial, observational trial, where, for example, in older patient, older than 70 years old, probably the use of steroids may increase the mortality. So I think that we have to move from trials during the surge, during the crisis, to more specific trial with differences in inclusion criteria. For example, it's completely different to use steroids, 6 milligrams of dexamethasone or methylprednisolone in patients with or without immune paralysis. And immunosenescence is a point. So it was in some way expected that steroids in patients with viral replication and immunosenescence, you can increase the mortality because the viral replication can continue, can persist in the patient. So now, I had in my slide, I skipped the slide, but probably the use of steroids in one for all is not correct. In terms of which is the right dose, I think in patients with a very important pro-inflammatory situation, very early during the COVID-19 course and without other co-infection, I think that the use of dexamethasone may be in a dose dependent on the weight of the patient is a good approach. Until the patient had a normal compliance in terms of lung compliance of the and non-compliance. And in this case, we use this kind of approach recommended by the guidelines. And we switch to high dosages of methylprednisolone using data coming from the RDS network published some years ago, I think 15 years ago, where after 1 week of acute respiratory dysfunction and with low compliance, probably the use of high dosages of methylprednisolone for 14 days could be useful in patients for decreasing the rate of, I don't remember exactly, days free from ventilation or mortality, I don't remember now. This is our approach now. So at the beginning, dexamethasone, maybe 6 or 12, it depends on the weight of the patient. I think it's not crucial. And then we move in patient intubated with the low compliance. Of course, during protective ventilation, we use methylprednisolone at high dosages.
Okay, Charlotte, can I put the same question to you then, specifically around pulsed methylpred in those patients who we've all seen with the stiff, probably fibrotic lungs? Support it, or should we do a trial?
I think we need to do a trial because we don't know. We've never known the answer in ARDS either. There's lots of people who are evangelical on both sides saying that actually doing it was associated in some older trials, particularly if you're doing it after 14 days, it's associated with increased mortality in the ARDS population. And I think the other thing to say is that we're probably not treating fibrosis with our increased doses of methylprednisolone, because once tissue has fibrosed, it's fibrosed. I know of no data that suggests steroids cause it to not fibrose. We're treating the inflammation that hasn't yet got to being fibrotic tissue. And so there's probably an intermediate house. Lots of what we do in our practice is actually based on that done in other branches of respiratory medicine for interstitial lung disease, for things like usual interstitial pneumonia trials. And we know it doesn't work for that, but it does work for other types of NSIP or other interstitial lung diseases. Even in that setting, we still don't know what we don't know a lot of the time, and we need more trials.
Excellent. So there's a question here about when we should use tocilizumab. So I'll go back to Charlotte there.
Like so much, slightly complicated. So the data from recovery suggests that if you are inflamed, and by that they used a CRP cutoff of 75, and you required oxygen or had respiratory failure, so oxygen saturations of 92 or less, or required oxygen to maintain your saturations, then you had a benefit in terms of 28-day mortality from tocilizumab. And then the REMAP CAP eligibility criteria were slightly different. They were people who were admitted to intensive care requiring cardiovascular or respiratory organ support within 24 hours of their admission to critical care. And they also suggested a benefit from tocilizumab. So the way we currently use it in the UK is a kind of hybrid eligibility criteria. If either you're early on and not critically ill and inflamed and need oxygen, or you're critically ill, but earlier rather than later, obviously. Just to say that people often talk about recovery it being a second randomization that could occur up to day 21. Actually, the median time to randomization for the second randomization was 2 days after coming into hospital. So they were actually getting it quite early, despite the window in the protocol.
Okay. Oh, sorry, Massimo. Yeah.
Can we change our roles? Now I just have a question to you and Charlotte. After the experience and the trial on the use of tocilizumab, will you use that in viral infection different from COVID-19 in a patient with ARDS at the beginning? I mean, if you have a patient with influenza and severe ARDS, with interleukin-6 measure at the beginning, after ICU admission very high, will you use tocilizumab or not now?
Personally, no. I would suggest that what we need to do is trials in those situations. I think there clearly is, evidence. This is the first time, we've got to remember, this is the first time in the field of sepsis management that we have seen the effective use of anti-inflammatories. Prior to this, they've either killed people or they've made no difference. But we have been dealing with very heterogeneous populations, and the good thing about COVID is that suddenly we've got a huge number of people who've all got the same disease, which we so rarely see in ICU. And so it does allow us to recruit large numbers of patients with a single disease with probably a common underlying pathophysiology. And suddenly then we can see, but I mean, I can see Charlotte sort of shaking her head as well. So I suspect she's going to agree here, or rather, I'm going to agree with her.
I was just going to say that influenza and COVID have really different pathobiology. We know that they have really different pathobiology. So that comes back to my point about what we see in one setting does not directly transmit to another. And so I think there would be significant risk and potential harm of saying, oh, well, it's another virus. They've got odds from another virus. We should, of course, give them tocilizumab without doing it in a research setting.
And I think the other thing that's vital about flu is that it often isn't just flu; it's flu and Staph aureus or Streptococcus pneumoniae. You know, co-infection. I think probably slightly more common in COVID in ICU than we might think. There's some interesting data coming out on that, but still not like flu, where co-infection is really important. And therefore, I think, exactly as Charlotte says, we're dealing with different diseases. I'm conscious that we are pretty much out of time. And I apologize to those who have posted questions we haven't had a chance to come to. But if I could just ask Massimo first and then Charlotte, just for a 1 minute summary of your take-home messages from today's webinar. So Massimo first.
My first final message is that we have a lot of information from COVID-19 in the last 2 years. More information in the last 2 years than in sepsis in the 20 before. And I think that the two pathologies are similar but not equal. And so I think that before to move from pathology to treatment, we have to wait some trial on the treatment, as you said now for influenza or other infection, because the risk now is to apply in the future the same treatment used in COVID-19 in other similar pathology, like ERDS from influenza or mycoplasma or other. And I think this is a very high risk. And I just will try to, it's important to say, please no, wait for some trial.
Excellent. Thank you, Massimo. And Charlotte.
I guess I would summarize and say, we don't know what we don't know. And when we don't know, we should try and learn.
Excellent. Well, thank you both. That's been an absolutely fascinating discussion. I hope our audience have enjoyed it as much as I have. That's been really enjoyable. So please do, continue people to stay in contact. There are the chat going on Twitter at the moment and Facebook as well. So do please continue those. And thank you once again.